Module 7 will cover in greater detail the clinical aspects and unusual circumstances that can occur with cell-free DNA screening. The a priori risk is the starting or background risk ratio of a certain condition for a person having a screening test. Some cell-free DNA tests use the maternal age-related statistics at gestation as the a priori risk. Most NIPT tests report a result without reflecting the individual's patient-specific chance for any given trisomy. The use of the combined or quadruple test results is a more appropriate approach. The SAFE test has the option to include the use of prior screening test results for the risk calculation. If the prior screening results are unavailable, the default is the maternal age-related risk ratio. This gives the most accurate, personalised and comprehensive prenatal screening result for pregnant women. Here is an example of the screening report showing the background risk, SAFE test risk score and the clinical summary. Here is a simple case study to highlight the different factors. A patient that is 21 years old would have a maternal age-related chance of 1 in 1,450. When the sample is tested, the cell-free DNA result may halve the chance, giving a result of 1 in 2,900, i.e. low chance. If the same patient had the combined test first and the result was 1 in 5, the overall result from the cell-free DNA test would be 1 in 10. The patient would remain high chance and a diagnostic test would be offered. The next topic looks at twins and NIPT. Routine screening in twins has a higher false positive rate, approximately 10%, with a lower detection rate than in singleton pregnancies. The most up-to-date systematic review of cell-free DNA screening in twin pregnancies reported 95% sensitivity and specificity for cell-free DNA screening in twins. In twin pregnancies, the cell-free DNA contribution of the two fetuses can vary significantly. It is possible that the fetal fraction of the affected fetus is below the threshold required for successful analysis, but there is a high contribution from the unaffected twin. NIPT in dizygotic non-identical twins. There is a greater likelihood for Down syndrome in most dizygotic twin pregnancies. Trisomy in dizygotic twins only usually affects one twin. The contribution of each twin's cell-free DNA into the maternal blood may vary. In dichorionic twins, or if the chorionicity is unknown, the SAFE test software assumes they are heterozygous and modifies the fetal fraction requirement accordingly. Fetal sex determination cannot be performed for dizygotic twins. NIPT in monozygotic identical twins. A high-chance trisomy NIPT result in twins cannot determine which twin is affected. Performance of cell-free DNA screening in monozygotic twins is the same as for singleton pregnancies. A vanishing twin is a fetus in a multi-gestation pregnancy which spontaneously dies in the uterus during early pregnancy. Vanishing twins occur in up to 1 out of every 8 multi-fetus pregnancies and may not even become known in most cases. Vanishing twins and NIPT. Early miscarriages are common when there is a chromosomal anomaly. It has therefore been suggested that vanishing twins may predispose to a high-chance result from a cell-free DNA screening test. There is no data to indicate how long the cell-free DNA from the demised twin remains in the circulation, but studies have suggested that 8 weeks from demise to testing would be a safe period, but often the date of demise is not known. If a vanishing twin is diagnosed, the mother should be advised that cell-free DNA performance is similar to that in a dichorionic twin pregnancy. It is important to note on the patient consent form if a vanishing twin is found. Sometimes a cell-free DNA test result indicates that the baby is high chance for a trisomy, but it is then identified either via an invasive diagnostic test or birth outcome that the baby does not have the condition. This is termed a false positive result, and it can occur due to a condition such as a vanishing twin or placental mosaicism, or it could be a condition affecting the mother, such as a partial duplication, maternal mosaicism for trisomy 21, 18 or 13, or if the mother has cancer. Mosaicism is when the genetic composition of an individual or organ is derived from two or more populations of cells with distinct carrier types. Confined placental mosaicism occurs when the cell-free DNA from the placenta is different to that of the fetus, and it can lead to a false positive NIPT result and diagnostic CVS test result. Consideration could be given to an amniocentesis test when positive cell-free DNA results are seen in a structurally normal fetus with low-risk combined or quadruple testing results. Isolated fetal mosaicism would always give false negative cell-free DNA results. Maternal duplication or mosaicism. If the patient reports a duplication or mosaicism or is affected with the full trisomy, it is likely to produce a false positive result due to the excess chromosomal material in the plasma. If there is a maternal translocation or rearrangement of a chromosome, then there is no contraindication to have an NIPT, as there is no extra DNA material present to affect the cell-free DNA assay. A balanced translocation is where a section from one chromosome swaps places with a section from a chromosome of another pair. NIPT is unable to report unbalanced transfers, and thus CVS or amniocentesis is recommended. Patients reporting a balanced translocation should be referred for further genetic or fetal medicine consultations. If a mother has cancer, this can affect NIPT, as the tumour can shed tumour cell-free DNA into the maternal circulation. Cancer cells have major chromosome anomalies that can be reported by cell-free DNA screening as a false positive result. Therefore, pregnant mothers with cancer are advised against having an NIPT screening test. A false negative result can occur when a pregnancy is thought to be low chance for a trisomy following a screening test, but later in pregnancy it is discovered that the baby is affected with a trisomy. Amniocentesis is the only testing method that can provide a definitive diagnostic result. False negatives can occur due to the use of an incorrect a priori risk, a twin pregnancy, or mosaicism between the placenta and fetus. Fetal anomalies and NIPT. An ultrasound is recommended before any NIPT screening. If a high nuchal translucency is measured greater than 3.5 mm, an NIPT is not recommended. The expectant parents should be made aware that the finding of a fetal structural anomaly is an indication for invasive testing, PCR and microarray CGH analysis. Fetal structural defects are associated with a higher chance of a non-aneuploid fetal chromosomal anomaly. In one study, 225 fetuses had an NT above 3.5 mm. In 24 of these pregnancies, a chromosomal anomaly other than a trisomy was detected. It is important that women have a clear understanding of the limitations of cell-free DNA testing with fetal structural anomalies. Another consideration is sex chromosome aneuploidies, or SCAs as they are often called. Some commercial NIPTs include the option for SCA screening. Studies have reported a lot of variation in the effects of SCA conditions. Many people affected remain undiagnosed in the general population. Sex determination can lead to incidental findings of sex aneuploidy that may have minimal significance and cause no harm or disability to a fetus. Until sex aneuploidy screening becomes part of routine clinical practice, this additional testing by NIPT is not recommended. False positive rates for sex aneuploidy screening remain high, thereby increasing the need for additional invasive testing. The recommendations by most leading institutional bodies such as the American College of Obstetricians and Gynecologists, the Royal College of Obstetricians and Gynecologists, the Nuffield Council on Bioethics and the UK National Screening Committee advise against screening for sex aneuploidy unless there is a clinical indication. In addition, some NIPTs can offer microdeletion screening. Advances in technology have created opportunities to improve and expand genetic testing. Again, like SCAs, screening for microdeletions is not recommended as part of routine prenatal screening at present, as it creates challenges for staff and patients, including misuse, unintended consequences, and misunderstanding. The SAFE test only screens for Downs, Edwards, and Patel syndrome. The Society of Maternal and Fetal Medicine and American College of Medical Genetics both highlight the fact that routine cell-free DNA screening should not be performed for microdeletions and microduplications. Screening for microdeletions and microduplications can lead to a high false positive rate with an associated increase in invasive testing. This goes against the principle of screening in pregnancy, which is to reduce invasive testing rates and parental anxiety. What about fetal sex determination? Most couples wishing to find out the sex of the fetus can be informed at the anomaly scan performed between 18 to 22 weeks. It can also be carried out with some NIPTs. The majority of the motivation to find out the sex of the baby is for preparation and curiosity. It is sometimes important for certain genetic conditions to know the sex of the fetus, sex-linked conditions. In March 2017, the Nuffield Council on Bioethics published a report that advises the elimination of sex determination in the private sector. It was advised that NIPT should not normally be used to test whether a fetus has a less significant medical condition or impairment, or to find out whether the fetus is a carrier of a gene nor reveal non-medical traits including sex. Sex determination is not offered by the SAFE test within NHS trusts in line with these recommendations. This is not applicable for patients with inherited genetic conditions. Patients with inherited genetic conditions will be offered genetic counselling and support to discuss the options available to them. Sex determination is often requested by genetic teams prior to diagnostic testing for sex-linked conditions. A sex-linked condition is described as an alteration in one gene on the X chromosome and causes a condition in males. Examples include haemophilia and Duchenne muscular dystrophy. Cell-free DNA testing can be used to determine the sex of the fetus when medically indicated. This gives patients the opportunity to decide if an invasive test is beneficial.